question, is there or is there not LV dysfunction or acute MR or VSD or free wall rupture, such as what you've heard and seen?
¿Sí están escuchando?
Sí, escucha muy bien, doctor.
Ah, perfecto. Ok. Muy bien. Entonces ahí vamos, chavos.
In the prior talks. So in selecting a test, first formulate a question and then consider the pros and cons of obtaining the answer. Next slide, please. So to recap, this is a 52-year-old man with a delayed presentation of MI. His initial evaluation indicates shock, as has been summarized, with clear inferior ST elevation with evolving cues and pulmonary edema on initial chest X-ray. The POCUS and TTE show the VSD, and it excludes, very importantly, other structural abnormalities which we need to know about to treat the patient properly: acute MR, free wall rupture, or other post-MI complications. It also excludes, in this case, significant chronic or pre-existing disease which may alter immediate care, such as critical aortic stenosis, which can, of course, coexist with coronary disease. In this case, the TE and the CT didn't add any additional information, but confirmed the VSD and the other transthoracic findings. And then finally, the form of imaging that we haven't discussed yet, the coronary angiography and left ventriculography, which is coming, are imaging, and these confirm the findings and enable therapeutic procedures. Next slide. So what questions in this patient at what stage of his workup can imaging answer that will change outcomes? Our thinking about the patient, concomitant disease compensation, and our treatment, such as emerging cath for probable PCI and VSD closure. What are the cons? Obviously the costs. The risks are the risks of the test, and there's the risk to imaging staff of exposure to COVID. But I think the most important con of additional imaging in this patient is delay of definitive treatment, possibly associated with further loss of myocardium, cardiac decompensation for continued volume load and pulmonary hypertension with congestion, worsening acute kidney injury, and so on. Basically, he could go down, have a downwards clinical spiral. Next slide. So the best imaging strategy for this patient is the best test, the right test for the right patient at the right time, done in the right way, of course. POCUS is quick and it's easy, but only if there's good expertise. A misdiagnosis on poor images can be fatal. The transthoracic is diagnostic and provides all the information needed to exclude other pathology and immediately perform the therapeutic procedure, rarely more than a short wait. Angiography and ventriculography are imaging required for definitive therapy, and other images bring longer delays, higher risks, and little additional information. Next slide, thank you.
Thank you so much, Dr. Douglas. Next, we have Dr. Mahadevan, who will describe the cardiac catheterization lab perspective on ACS shock and interventions.
Thanks very much, Christina. Next slide, please. So this patient basically was taken to the cardiac catheterization laboratory as a part of his treatment strategy, and it reveals a occluded right coronary artery on the on the left-hand side of the screen, as you can see. And that's what revascularized with the stent, the occlusion in the mid-RC was relieved. There is some distal thrombus, which is still visible here. Next slide, please. So the patient did undergo, that is a left coronary system, and the angiography on the left-hand side shows moderate LAD disease, but on some circumflex disease, but otherwise, nothing terribly significant. And the cardiac catheterization hemodynamic study is shown pictorially on the right-hand side of the screen, which shows a right atrial saturation of 50% with a mean RA pressure of 25, indicating he is in heart failure. But however, note the RV sat is 83%, so it's a significant step up from the right atrium to the right ventricle, indicating that there is a shunt at the ventricular level shunting from left to right. And as you can see, the RV systolic pressure is elevated to 59. The PA pressure mean is again elevated to 36. And the wedge pressures are again elevated at 28, indicating overall global heart failure, with the calculated QPQ as 1.95, indicating a significant left to right shunt. Next slide, please.
A ver, jóvenes, ¿ahí están todos? ¿Me escuchan?
Sí, doctor.
Déjenme regreso un poquitito. Ahí. A ver, no es que me aparece aquí en el centro eso. Bueno. ¿Cuál es el dato que les hace el diagnóstico? Esto está muy sencillo para los R3. De la complicación mecánica de este infarto. A ver, Poncho. ¿Ahí estás, Poncho, todavía? ¿O está en la playa? Yo creo que está en la playa. Miguelito Reyes, ¿cómo haces el diagnóstico de acuerdo a los datos que está poniendo acá del cateterismo, el doctor?
Pues,
Miguel.
pero la lesión que hay a nivel de la arteria coronaria derecha que ahí se mostró, y también la medición de los shunts, el QPQS, ahí el paciente tiene un QPQS que es de 1.9, nos habla de que hay un cortocircuito en shunt de al menos un tamaño moderado.
Ok, pero ¿cuál es el dato así característico para la CIB en este paciente? Que lo dijo el doctor, nomás que de repente algo muy rápido.
Se refiere a que se ve el flujo en la ventriculografía, por un lado, y por otro, pues la oximetría.
La oximetría, ¿no?
Es el salto oximétrico.
Exactamente. Esta es la saturación de la aurícula derecha. ¿Sí la están viendo todos? 50%, ¿no? Sí. Razonablemente baja, porque es como si lo tomáramos si pusiéramos un catéter venoso central, ¿verdad? Y entonces documentáramos una saturación de la sangre venosa central del 50%, lo cual ya es como nos traducen que el paciente está en estado de choque, ¿no? Muy bajo gasto. Y un salto oximétrico de 50% a 83% en el ventrículo derecho, ¿ok? Entonces se está mezclando la sangre oxigenada del ventrículo izquierdo hacia el ventrículo derecho, ¿ok? La otra cosa importante, ¿qué otras cosas importantes mencionó en el cateterismo? Ricardo.
Bueno, es que no lo entendí bien a toda, pero bueno, que había datos de falla cardíaca, pero más bien lo digo por la ventrículo.
No, este es el diagnóstico de insuficiencia cardíaca. Sí, PCP de 28, muy elevada la PCP. Sí, es una disfunción del ventrículo izquierdo, no una presión telediastólica, el ventrículo izquierdo muy elevada. Sí, y hipertensión pulmonar, ¿no? 46 de distólica en la pulmonar. Sí, con 20, por aquí se ve como con 29 de diastólica. ¿Ok? Bueno, muy bien. ¿Algo más que quieran agregar aquí? ¿No? Ok, vamos a seguir.
Level shunting from left to right. And as you can see, the RV systolic pressure is elevated to 59. The PA pressure mean is again elevated to 36. And the wedge pressures are again elevated at 28, indicating overall global heart failure, with the calculated QPQ as 1.95, indicating a significant left to right shunt. Next slide, please. So this is an angiographic appearance of as you can see, the catheter is in the left ventricle, and you can see, flow through the VSD, and the left ventricle is here, and the right ventricle fits in here. This is the apical four-chamber equivalent type of view, and this is a different case where we did put a device, and we're able to include this apical VSD in another patient. Next slide, please. So this is the echocardiogram, which has been shown here previously, again showing a muscular septal VSD, as you would call it. And as you can see, there is a device here, located in the septum, which is virtually causing, cessation of flow, indicating a good outcome in this particular case. Next slide, please. So this was a pre and post, TE images in another patient who presented with a similar problem. As you can see, there is a very apical VSD there, as pointed out by the pointer, and there is a device in here which is closed defect, as you can see, with the very little. In fact, there is no flow across it. And here again, similarly, again, further echo images showing the same thing. And this is a 3D representation of that, again, showing a well-seated device across the interventricular septum. Next slide, please. So visualization of apical VSDs is not particularly ideal with TE, can be challenging and difficult sometimes. So at least in my practice, I always also use the transthoracic as an adjunct, to just confirm device position and make sure we are well seated. The VSD rim in the apex and very apical VSD is again difficult, and again to assess the integrity of the device. And size assessment is also difficult, and it's usually by choreography and color flow examination. So if you really need some good echo images, balloon sizing is not something we routinely perform in this situation because of risk of tearing the septum further. So you go by echo sizing and deploy an appropriate device. Next slide, please. So this is the technique where we go through the left-hand side of the heart, and the wire is passed through the VSD and taken up into the right ventricle and usually into the PA, and the snare there using a snare, and then exteriorize out through the vein. So you create an AV loop, and then you go through the right-hand side. As you can see, in this case, the snare is snaring the wire across the VSD, and it's exteriorized. Next slide, please. So the post-MI device is preferable because of the large waist, and 24 millimeters is the largest device. If it is larger than that, you may have to consider using an ASO occluder rather than a post-VSD device. And device confirmation may be difficult to confirm. So next slide, please. So I won't go through this in detail, but we'll just rattle through very quickly. This is the AMPLATS UNC registry of the post-infarct VSD devices. And as you can see, there is a fair spread between males and females. And the next slide, please. And the average age was 73. And pre-procedure results, acute procedural success around 60%. Although if we move to the next slide, please, we will see that, in the survival at 30 days, again, around 50%, and survival, presumed survival at 30 days, what you would expect it if they hadn't been was lesser. So it does make a difference, but nevertheless, still there's a challenging group of patients. Next slide, please. So this was a continued use data slide, and on 243 patients from the United States. Next slide, please. As you can see, the implant success has gotten better, with increased physician experience, so around 80%, and embolization is getting lower. It's only around 5% currently, but unfortunately, early deaths remain a major problem. 40% of patients. However, if you survive the first 30 days, your chances of surviving are much better. Next slide, please. So ECMO is increasingly used in these patients for support, although this could be done with impella support and balloon pump support. After closure, LV volume overload can occur in patients on ECMO, so it's something to watch for. And in that situation, you may need an ECMO Pella situation where you may need an impella to offload the LV. Next slide, please. So post-MI VSD closure has good technical success, and it's used as part of the humanitarian device use protocol, HDU protocol, under which every case has to be reported to the FDA for outcomes, and it can be used as a definitive therapy or as a bridge to surgery for hemodynamic stabilization. Unfortunately, the 30-day mortality is still high. However, the patients are able to survive that period, then subsequent survival is pretty good. Thanks again for the opportunity, and wonderful to talk to you all.
Thank you so much, Dr. Mahadevan. Next, we have Dr. Kim, who will describe to us the cardiothoracic surgeon's perspective on shock.
Thanks for having me as part of this great session. Next slide. So as a cardiac surgeon, when deciding whether to place a patient with post-infarct VSD on VA ECMO, I need to assess the clinical status of the patient. Depending on the size of the VSD, the patient's baseline ejection fraction, and then on top of that, compromised function as a result of the infarct, the patient's ability to compensate for the volume overload, concomitant cardiac lesions such as coronary disease and mitral valvular disease, and underlying comorbidities, The patient can have a range of clinical presentations from moderate heart failure to cardiogenic shock. Next slide. The reason that clinical status is important is that it is notably associated with increased mortality after surgical repair. In this retrospective multi-center analysis of the Japan adult cardiovascular surgery database of approximately 1,400 patients who underwent surgical repair of post-infarct VSD, operative mortality was 33% in all comers and ranged from as low as 16% in elective operations up to as high as 41% worse in patients with cardiogenic shock and those who underwent emergency or salvage surgery. An analysis of the Society of Thoracic Surgeons adult cardiac surgery database from an earlier decade showed similar findings. Next slide. While intra-aortic balloon pumps have traditionally been used in patients with post-infarct VSD who present in or progress to cardiogenic shock, VA ECMO is playing a growing role in stabilizing these patients prior to surgical repair. The experience is limited to small case series, but the outcomes in those patients have been reasonable. ECMO allows the patient's hemodynamics and organ function to improve or recover to the point that they can survive a second trauma of surgical repair with cardiopulmonary bypass. One further note as to technical limitations of being able to support patients with VA ECMO, they need to have adequate iliofemoral arterial access, usually a diameter of 6 to 6.5 centimeters. The ability to perform cannulation in the cath lab or a hybrid OR with fluoroscopy or at the bedside with the assistance of TEE to confirm wire placement in the descending thoracic aorta for arterial cannulation and in the SVC for femoral venous cannulation can be very helpful in avoiding complications. Also, the patient should not have more than mild aortic insufficiency. That can lead to LV distension and diminish the effectiveness of circulatory support. Thank you.
Thank you, Dr. Kim. Now we're just going to do a brief clinical recap, and then we're going to get to an audience response because we do want to hear from all of you. So we've heard our patient present with a late STEMI. The right coronary artery was the culprit lesion. He did undergo drug-eluting stent placement. It was found to have a left to right shunt. It was placed on VA ECMO by CT surgery. He then underwent mechanical ventilation for respiratory failure, which was also complicated by alcohol withdrawal. CRRT was initiated for volume removal. He was initiated on pressors as well as inotropes. And day 9 after his presentation, he was still in the ICU. So now we'd like to hear from all of you in our audience. We're going to activate our next poll, and also please feel free to submit any questions and we'll ask our panel for their insight. Yeah. So our first question is, what should we do next? A, refer to surgery for a VSD patch closure. B, refer to interventional cardiology for percutaneous closure. Or C, conservative management, given that he's in shock.
I don't know if they're running there. Oh, there we go.
All right, we're getting our responses in. We have a few people already voting.
We will let it run for just 10 more seconds. It looks like most of the audience think we should refer to interventional cardiology for percutaneous closure. I think I would like to ask Dr. Mahadevan and Dr. Kim, maybe Mahadevan first. What would make you sort of excited about taking this particular patient to the cath lab versus maybe refer for surgery? And then maybe Dr. Kim can answer the same question.
Yeah, thanks, Kirsten. I think part of the thing which we do know is the size of the VSD. I mean, as long as the VSDs are kind of, around no more than 20 millimeters in diameter, I think we usually can get very good results, and also the location. I mean, if it's more in the mid-muscular septum with deficient, reasonable rims, I think the chances of a successful closure and the device staying stable are much higher than, someone with a very deficient rim, as might be in this case, with a very apical VSD. And, those two big criteria, I would say, from an interventional point of view.
I think from a cardiac surgery point of view, yeah, the VSD was apical, so As Dr. Mahadevan pointed out, I'm not sure how well the device would fix there to the tissue. The tissue in post-infarct VSD is pretty fragile and friable, so that's always something to consider. He's a young man, so advanced age is associated with poor outcome after surgical VSD repair, but he's on the younger side. I didn't see, he has acute organ dysfunction related to shock, but I didn't see that he was preoperatively on dialysis, had COPD with poor lung function. So that's good. I do think that being on VA ECMO and allowing him a chance to stabilize will improve his chances with surgical repair, but I would not turn this patient down for surgery.
Is there any of the other panel members that would like to comment on the approach in this patient? Otherwise, I think we will just see what was actually happening to the patient.
All right, so first we'll turn it back to Dr. Kim, who will describe to us post-infarct VSD repair from, again, the cardiothoracic surgeon perspective.
Okay, next slide. So surgical repair involves establishing cardiopulmonary bypass. In this patient, it could be via his existing femoral cannulas, which were placed for ECMO, or if the surgeon feels that the cannulas will provide less than optimal arterial inflow or venous drainage, central cannulation in the aorta and bicavally can be performed. The aorta will be cross-clamped, the heart arrested with cardioplegia, and an incision is made in the left ventricle through the area of infarct to enter the left ventricular cavity. Prosthetic material, whether it's bovine pericardium or Dacron or a core matrix, will be used to patch close the VSD and to repair the ventriculotomy. The surgeon will need to take into account concomitant cardiac lesions, including significant coronary disease or mitral valvular regurgitation, and decide whether to perform CABG and or mitral valve repair or replacement. Next slide. So on the left, you can see an illustration of an anterior infarct. On the right, you can see that once you've made an incision through the anterior infarct, you can view the VSD from the left ventricular side of the septum. Next slide. There are several techniques for patch repair. Conceptually, the two-patch technique is easier to visualize. Basically, you'll use two circular patches to separately repair the VSD and then the ventriculotomy that was made through the infarct. So the illustration on the left shows the patch used to repair the VSD. Those small little squares are pledgets that reinforce the multiple sutures that are placed to secure the patch circumferentially. And then in the middle illustration, you can see the second patch that was used to repair the ventriculotomy, again with multiple sutures reinforced with pledgets. The reason that you have to use so many pledgets is that the tissue is kind of mushy from the infarction, friable and fragile. And then the illustration on the right is a cross-section of the left ventricle and the right ventricle. And you can see the two separate patches that were used to do the repair. Next slide. The one patch technique uses one patch to exclude the VSD and the ventriculotomy. And again, after making an incision through the area of infarct, in the illustration on the left, you can see that quite a large patch is used to sew not to the infarcted tissue around the VSD, but to healthier left ventricular tissue in a wide area that will exclude the infarction, including the VSD as well as the ventriculotomy repair. So in the middle illustration, the ventriculotomy, rather than being repaired with a patch, is actually repaired primarily with sutures that are buttressed with two long strips of felt or bovine pericardium. And then in the illustration on the right, the cross-section of the two ventricles, that really gives you a sense for what infarct exclusion is. You can see that the patch is secured to the left ventricle in healthy tissue away from the area of infarct. And then when the left ventricle fills with blood or contracts, the force or pressure would be transmitted to the patch rather than to sutures placed in infarcted tissue or to the ventriculotomy. So both repairs can be, after you've done the surgery, can result in a residual VSD, possibly from tearing of the sutures that secured the patch because they were placed in fragile tissue. One last note, while the technique and adequacy of the surgical repair is important, just because the VSD is repaired doesn't mean the patient will be able to separate from cardiopulmonary bypass. So the patient will likely require continued vasopressor and inotropic support and may need adjunctive support of the RV with nitric oxide or epoprostenol. And also the patient may need continued support with VA ECMO, either centrally with an open chest or peripherally with or without a closed chest, for several days until biventricular function has recovered. So communication between the cardiac anesthesiologist and cardiac surgeon is key to getting the patient to a stable place, enough to be able to get out of the OR, transport to the ICU, and have a chance at recovery. Thank you.
Thanks, Dr. Kim. Here we have our patient's post-VSD repair echocardiogram with and without color, and we can see a small residual defect there. Next, I'd like to introduce Dr. Ortoleva, who will describe to us perioperative considerations in this patient and others like him.
Thank you very much for the introduction, and thank you for inviting me. So I'll be discussing the perioperative critical care and cardiac anesthetic management in delayed presentation and MI. Next slide, please. So for the preoperative assessment for this patient, obviously he's already been through quite a lot, being cannulated on VA ECMO and requiring mechanical ventilation. Because he's been on ECMO for 9 days, hopefully some of his multi-system organ dysfunction, including his renal insufficiency, has possibly recovered, or at least he's had volume removal with CRRT. Really, some of the key things here are basically the ability of the patient to accommodate a TE probe, given his drinking history and the possibility of varices. In addition to the importance of a perioperative TEE, because it does change management, and one large retrospective review of about 12,500 patients found that up to 9% of cardiac surgeries may actually have changes as a result of the intraoperative echo, both the pre-bypass and the post-bypass examination. Next slide, please. So this patient is already intubated. This patient is already sedated. This patient is already on ECMO. Really the important things for anesthetic management at that point are, one is the way you deliver anesthesia. So if a patient is on VA ECMO, not all of the blood that patient has is continuously circulating through the pulmonary circuit. As a result, you actually can't use inhaled agents for those patients, or they can actually have a recall of the surgery. So all the anesthesia is given through the IV, just as sort of an interesting side note. Ventilation is actually going to be important as well. The circuit can certainly do some of it, but being on VA ECMO does not preclude mechanical ventilation. You typically must still mechanically ventilate the patient as well. Carbon dioxide levels and pH are going to be important in the pre-bypass period because those affect pulmonary vascular resistance and recirculation, and they may even have an effect on a lung injury after the surgery as well. Other issues sort of that are important are, because the patient has been on ECMO for some time, heparin resistance may occur, as well as being judicious with fluid management in these patients. Next slide, please. So for intraoperative echocardiography, it's just as with echocardiography in any other circumstance. One of the things that I just want to really stress the importance of is that context, particularly in patients that are undergoing mechanical circulatory support, is very important. So the ejection fraction of a patient on VA ECMO support at 4 liters is going to be different from what it is at 2 liters. And so one of the things that I do, and that most of my colleagues do as well, is providing context even on the echo images on what the degree of mechanical support the patient has while you're imaging the patient's myocardial function, while you're assessing their valvular pathologies, et cetera. These patients frequently have pleural and pericardial effusions, and patients that are on mechanical support also frequently have sort of other mechanical complications as well. So the importance of the intraoperative and really perioperative echocardiography can't really be stressed enough. I list pulmonary pressures with echo exam because in the particular case of this patient, they don't necessarily mean as much as they would in a patient not on mechanical circulatory support. So really, it's actually your pulmonary artery catheter that's going to be determining a lot of
1 minute, please.
Thank you. I have a chart on the right side that just shows the percentage of interventions in patients receive just normal ejection fraction and better cabbages based on their pre and post-operative echo exams. Up to 1 in 19 patients in the pre-bypass period will have a change, and up to 1 in 70 in the post-bypass period as well. So it's very important in this patient. Next slide, please. So this patient most likely, as Dr. Kim had mentioned, is going to stay on ECMO after the surgery. If the decision is made to wean, it requires very close communication between the surgeon and the anesthesiologist, because you don't want to get in a situation where you're on such high doses of vasopressors that the patient is crashing and you require emergency reinstitution of ECMO. So earlier is better for the purposes of organ dysfunction. Survival is sort of variable depending on when this is corrected. And for weaning of mechanical circulatory support in the ICU, frequent echocardiographic exams are important. You're going to be dealing with coagulopathy from anticoagulation, which sometimes has to be stopped in the postoperative period. And also, frequent echocardiographic exams can help guide weaning, in addition to a pulmonary artery catheter, giving you information about pressures and whether or not there's still a step up. As one final aside, I'll just mention that if pulmonary status has significantly declined during the surgery, you may not see a step up if there is a residual VSD, because the blood flowing through the pulmonary circuit will not be oxygenated. So it's just important to use an echo to verify VSD resolution as well. Thank you very much.
Thank you, Dr. Orduleva. Now we have an additional discussion by Dr. Riggolin with respect to echo follow-up.
Thank you. So how do we follow a patient who has undergone a STEMI, and particularly one that has suffered a ventricular septal defect or other mechanical complication? And the echo can be useful to identify residual LV dysfunction, evidence of LV adverse remodeling, assessment of RV function, assessment of diastolic function, residual valve disease, presence of thrombus, and residual ischemia, particularly with the use of a stress test. The timing and frequency of imaging during follow-up is dependent on the underlying pathology of the patient, the clinical state of the patient, and the specific clinical question being asked. Since there's so many things that can go wrong with a patient who underwent a myocardial infarction, the type of imaging and the frequency really needs to be individualized. Next slide, please. Now, what about this patient with a VSD? What kind of outcomes do we expect, and what kind of imaging are we going to have to do? You've already heard from several prior speakers that the prognosis can be quite poor depending on the status of the patient and the emergent nature of the surgery. Here's another study that proves the same point. This is a retrospective analysis of 537 patients who were identified using the combined STS and Medicare-linked databases who underwent surgery for post-MI-VSD. In this cohort, the 30-day mortality was 29%. At 1 year, the mortality was 39%. With elective cases, the mortality was 13%. In emergency cases, it was 69%. So you can see, again, in this, similar to what was previously discussed, that sending a patient on an emergency basis to surgery can have a very poor outcome. Even in the individuals who survive out to 1 year, however, many of them required readmission for one reason or another. And in this particular cohort, the readmission rate within 1 year was 32%. Next slide. From this same study, the regression model for 1 year survival again shows that age, emergency status at the time of surgery, and the need for a concomitant cabbage were all associated with poorer survival. Next slide. And again, demonstrating survival estimates on the left-hand side are those, the survival for all patients or all subjects that were in this study. And you see again the breakdown that the survival is worse for those who undergo emergency surgery, the best for those who undergo elective surgery, and in the middle for those who undergo urgent surgery. On the right hand of the screen is a survival of the individuals who survived to hospital discharge. And you can see that out to a year, the overall survival, of course, is going to be better than those who didn't make it out to a year. But despite that, you see that the breakdown between elective, urgent, and emergency surgery is similar, and that emergency surgery carries a poorer outcome. Next slide. So in summary, patients who undergo surgery for post-MI VSD are at high risk of cardiovascular complications and death. Risk is greatest if the surgery is emergent, the patient is elderly, or also needed a CABG. Readmission rate is high, even for those individuals who survive. So all of this tells us that close clinical follow-up is needed, particularly since within the first year following surgery. And serial echo imaging is going to be useful to follow LV function and other sequelae of the MI, particularly those for those with residual heart failure and those at risk for required readmission to the hospital. Thank you.
So much, Dr. Riggolin, and thank you to all our speakers. Our clinical update for our patient: he underwent a sternotomy, cardiac cannulation, and bypass. He had 2 VSDs repaired with Dacron patches. He was converted from peripheral to central ECMO. He had a chest tube and pacing leads. CRRT continued for volume removal. He continued on pressor support for about 4 days, and inotropic support, mechanical ventilation for 11 days. His course was complicated by withdrawal. He was eventually weaned off of ECMO 5 days post-op. Here are his post-op CT and MR images demonstrating a little small outpouching here in the basal inferior wall. So we want to wrap up our case. We're so thankful to all our speakers and to all of you. We have some questions that have come in, which we'll address with our panel. Feel free to keep them coming.
So we have just a few minutes left, and thank you to all the expert panel. There is a question for Dr. Kim. What is the current thought on timing of post-infarct VSD surgical repair?
So again, as you've seen, the results for patients who are in shock are not very good. And so I would think that you would want to stabilize those patients with a period of ECMO if possible. With regard to whether to do it before discharge versus later, after you've given a chance for the tissue to kind of scar and become more amenable to suture placement and repair. I think many patients won't be able to tolerate the volume overload and heart failure, depending on the size of the VSD and concomitant lesions. So I would say that earlier repair, even though other papers have shown that outcomes may be better if you wait, that may be related to selection bias from surgeon designation that the patient is no longer an operative candidate. So I would say that earlier repair in a semi-stable or stable state would be ideal as to waiting a longer period of time.
There's another question, and it has to do with if the ventricular septal defect size or location is not appropriate for device closure and the patient needs to go for surgery, can you still use a drug-eluting stent? They would like interventional cardiology, the cardiac surgeon's perspective on this, please.
Yes, the patient will bleed from the antiplatelet agent and maybe after having been loaded with Plavix or other agent, but you can address that with platelet transfusion during the case, and you can still resume antiplatelet agent postoperatively. So that's not a deal breaker for a surgical repair.
Dr. Mahadevan, if you had this patient and took him to the cath lab, would you have upfront a consideration already thinking maybe this guy would need a VSD surgical repair and you would take a different approach, or would you just put the drug-eluting stent in?
Well, I think it's a good question. And I mean, if you kind of know beforehand very clearly there's a significant VSD and the surgeon is willing to operate, then I would certainly maybe consider using a bare metal stent, you know, if it's a large vessel non-diabetic patient. Otherwise, there isn't a whole deal to be gained. As Dr. Kim said, most surgeons are happy to operate on Plavix, you know, albeit, you know, it technically makes it more challenging surgery. But I certainly, yes, if there is a clear, you know, indication the patient is going to go for cardiac surgery and it's a large size vessel in a non-diabetic patient, certainly would consider implanting a bare metal stent to avoid a risk of subacute thrombosis, you know, post-surgery period.
I think we just have time for one more question. Who reads the echo done in the OR? Anesthesia or cardiology? Maybe the panel, we can take a quick raising hands. Who in their institution has anesthesia read the echoes? And who has cardiology do it in the OR? So it varies. I think it depends on institution. We are at the end of our session here. I really want to thank everybody on ASE for this opportunity. This was the kickoff of the first episodes of CARE. Thank you to Dr. Abu Saeed, who really did a tremendous job on this one, and thank you to our expert panel. Have a great afternoon, everybody.
Thank you to our panel and everyone logging in.
Ok. A ver, entonces, comentarios. ¿Algún comentario que quieran hacer, referentes?
Sí, doctor, pues, vimos un escenario pues muy trágico de un paciente. O sea, digamos que lo peor que podemos ver en cuanto a presentación y complicaciones mecánicas. Y lo que comentamos la sesión pasada, realmente en este caso en específico, pues está en un lugar en donde se tiene la disponibilidad de todo. Pero bueno, ¿qué hubiéramos hecho nosotros? ¿O qué hemos hecho nosotros? Ahí, a pesar de que sabemos o ya escuchamos que es lo mejor con la evidencia que nos presentaron los panelistas, que realmente está a nuestro alcance. Pero bueno, siempre es bueno conocer la opinión de expertos, ver cuáles son las modalidades que más benefician al paciente en cuanto al diagnóstico y en su caso el tratamiento. Y aún así, pues que la mortalidad es alta, ¿no? Pues me parece muy buen caso, me gustó. Pues nada más.
También algo que menciona de manera importante, los tiempos para llevar a la reparación. Es algo que siempre se ha discutido de cuándo llevarlos, y llevarlos de manera temprana, esperar a que el tejido sea menos fiable para poder realizar reparaciones. También creo que esa es una parte importante y que a pesar de la opinión de los expertos, ellos también hay opiniones divididas en quien sugieren llevarlo, esperar, aunque la evidencia pues es la realización del tratamiento. Y pues nada más.
Sí, creo que fue una de las dos discusiones. La otra discusión, ¿cuál fue acerca del tratamiento? ¿Que recuerden?
Sobre la revascularización, ¿no? Sobre la revascularización, de qué utilizar, si... No le alcancé a entender muy bien al doctor, pero sobre la utilización de stent metálicos, estén liberados de fármacos. También comentaron algo ahí sobre la antiagregación plaquetaria, ¿no? Durante el procedimiento, posterior al procedimiento.
Exacto, fíjense cómo no comentaron nada acerca de los nuevos, ningún nuevo antiagregante, ¿no? O sea, se refirieron mucho a La doctora, la cirujano, pues en realidad ella dijo así como que no, le ponemos su sangre y eso, y para nosotros no hay mayor problema con que lo hagamos, que le hayan puesto un stent liberador de fármaco, ¿no? Sin embargo, el intervencionista sí fue lo que dijo, ¿no? Que probablemente no sería más complicado el posoperatorio y todo, poniendo un stent liberador de fármaco que un stent metálico, ¿no? Esa fue otra de las discusiones, pero vean cómo aquí en realidad no hubo mucha discusión. Ellos vieron que estaba tapada la coronaria derecha, la desocluyeron, ¿no? Y de ahí el soporte hemodinámico fue dado con ECMO, ¿no? O sea, ya nadie mencionó el balón de contrapulsación aórtica ni nada. Se dijeron totalmente al ECMO, como soporte de puente hasta llevarlo a la cirugía. Ok.
Sí, ahí la discusión fue ECMO y en algún momento mencionaron, bueno, y pudiera ser Impela, pero ya el balón prácticamente ellos, no sé si
No,
lo conocen o lo mencionan.
Ni lo conocen igual. Ok, perfecto. ¿Algo más, Eric? ¿Algún comentario?
Pero realmente, pues, ahí pues tienen un buen cardio team. Primero, pues el clínico, pues, que es el que diagnostica, y pues el método de imagen multimodal que tienen, pues es muy bueno. Y pues pueden detectar este problema y optimizar los tiempos y posteriormente pues resolver. Pues ellos lo resuelven por vía quirúrgica y pues siempre lo que hemos visto que actualmente pues los equipos de asistencia ventricular pues pues no mejoran la sobrevida, pero pues nos dan el tiempo para resolver el problema. En este caso pues el problema que tenía era un defecto septal que posterior a un infarto y pues pues nada más ellos sí pues tienen un buen cardio team que puede resolver este tipo de problemas. Pero en nuestro medio, pues yo creo que nos hace falta, pues, incluir a más personal para tener este cardio team que tienen ellos.
Ok, perfecto. Muy bien. Bueno, pues entonces la dejamos aquí. Mañana a las 7 realizamos la clase con el doctor Leiva. Y toca Miguelito Reyes, ¿verdad? Bueno, nada más acabamos de ver lo de los tipos de catéteres, ¿no, Miguel Galicia?
Ok. Catéteres
Sí, unos
contraste.
tipos de contraste, catéteres, y ya para que le dejes, andamos en unos 10 minutos, y que le dejes a Miguel Reyes para ajustarnos al programa.
Muy bien.
Cosa. Y les encargo artículos ya para volver a retomar la siguiente semana los artículos. Y si quieren alternamos artículos. Esto va a estar disponible, lo de los casos y eso. Vamos a alternar la siguiente semana con artículos y la siguiente semana vemos otra vez los siguientes casos, otro caso de lo que se presentará al Congreso, ¿no?
Sí, doctor.
Ok, perfecto.
Sí, doctor.
Bueno, mucho gusto. Nos vemos mañana a las 7.
Sí.
Vale, bye.
Gracias.